Well, here I am with Larry Jerrold, a good and close friend, a mighty interesting and unique fellow. And the May issue of the American Journal of Orthodontics and Dental Facial Orthopedics, I always read Larry's litigation and legislation because I find it quite remarkably interesting. Plus, Larry has a very unique way of expressing himself, kind of cutting to the chase. I guess that's sort of a New York thing, is it, Larry, would you say? Or is it just a Larry Jerrold thing?
Yeah, it's pretty much a combination of both.
Well, yeah, I find that quite engaging because I don't have to engage in too much guesswork and that type of foolishness. But Sword and Shield is the name of the editorial, which I thought was quite interesting. What was that about? Well, what Larry and I have been talking about before I hit the record button was the ladder of informed consent. Isn't that the way you put it, Larry, that it's risk tolerance? Explain just a bit more about that.
Well, we all have different risk tolerances. Some of us are more footloose and fancy-free. It doesn't bother us to be a little more loosey-goosey. Others of us have to do the real straight and narrow, and we have to conform to everything, write it down, dot the I's, cross the T's, that type of thing. And so when you look at the process of risk management regarding informed consent, and particularly the documentary part of it, how do we document that we obtained a patient's informed consent, which is an important distinction, by the way. We don't give informed consent. We get informed consent. What we give is information so that the patient can then grant us their consent to invade their bodily integrity and do whatever it is we're going to do. All right. So when you look at this risk management ladder, okay, the highest rung on this ladder, one could argue, would be videotape the informed consent consultation. Fabulous. Shows you absolutely everything that was discussed. Shows you absolutely everything that wasn't discussed because it's not in the videotape. Okay. The next rung down might be audio tape. Well, we know what happened in Nixon and Watergate, so maybe that's not the best example. But then if you keep going down this risk management ladder, you might have something where you have a blank form that the patient has to fill in their own handwriting. I was told my problem is, they write it in. I was told the following things could happen. They write it in, okay? You can feed them the answers, but they have to write it in. It can never be argued that they didn't understand because they wrote it, okay? The next rung down would be the classic forms that everybody uses, whether it's the AAO form or a proprietary form, or you buy it or you make it up, whatever. Patient initials a box, doesn't. Okay, that's the next rung down on the ladder. Then you might have the next rung where I write down exactly what I told the patient, and in the chart, patient initials it or signs it. Then the next rung down, I just write it down what I told the patient. Next rung down, informed consent discussed with the patient. Finally, what would be considered habit therapy. Oh, we discuss this with every patient before we start, without any specifics, but we always talk about it. So that's the ladder of documentation for informed consent. And again, that's all going to depend on your risk tolerance, the dental IQ of your patients, okay? How you want to conduct your practice. I can tell you that probably the two most important appointments in the entire life cycle of an orthodontic case are the initial screening appointment / record appointment and the informed consent discussion. This is where the rubber meets the road. This is where you make or break the doctor-patient relationship. And if you can get the patient on your side early in the ballgame, you are now working as a team, you're working together, it's real tough to have that breakdown because your communicative skills have gotten to the point where it doesn't allow for that type of breakdown, short of really creating some type of clinical disaster, which, puts somebody mentally at odds.